as well. Okay, so the recording is started, sorry. So all participants that register and stay on for at least 60 minutes per session for 4 out of the 6-week series will receive a certificate of attendance, and slides will be posted on the CDC and ICAN website. It will also be sent to all the participants via a link after the presentations, and presentations will be posted on the CDC and ICAN site, as I mentioned, if you do not get them on your link or via your email. And then for educational and training improvement purposes, we're also recording all sessions. And by participating in this session, you are consenting to the recording. So thank you so much once again for your participation. So without much further ado, we'll just get right into our program. And as I mentioned before, today we're talking about all things AMS, which is Antimicrobial Stewardship, and focusing on the impact of the pandemic on the new norm when it comes to infection prevention and control. So to talk to us or to discuss with us the antimicrobial stewardship and role of pharmacy with impact on COVID-19 is Ms. Achuzi Chola, who's a pharmacist with WHO Afro and with the Department of Health in Tanzania. So over to you, Ms. Achuzi.
Thank you very much for that introduction. So I'm actually from Zambia, not Tanzania.
Apologies, apologies.
That's okay. So let me see if I can start sharing my screen. Okay. Can you see my presentation? Okay. So yeah, we're going to have a look at antimicrobial stewardship and the role of pharmacists in the times of COVID-19. Can you hear me?
Yes, we can. So if all our participants and as well as our panelists, if you could just please mute your microphones so we can clearly hear the presenter. Thank you.
Thank you. Okay, so looking at antimicrobial resistance in Africa, there's some papers published between 2013 and 2016 showing 144 out of 1,513 papers. 40% of countries did not have recent AMR data, and the quality of the microbiological data was of concern. So there's high resistance to a number of antimicrobials that are commonly used in Africa, in Zambia as well, where we see
Zambia
88.1% pathogens resistant to it, and 26.7% resistant to penicillins in strep pneumoniae, and 80% resistant to trimethoprim, mostly used in our HIV patients. And ciprofloxacin resistance in Salmonella typhi was rare, where we also see carbapenem resistance common in Acinetobacter species and Pseudomonas aeruginosa, but not in Enterobacteriaceae. So Dr. Tedros of the World Health Organization, the Director General, has actually reiterated that antimicrobial resistance is a global health crisis that should be addressed with utmost urgency. So let's look at what antimicrobial resistance are actually doing in our society. These are drugs that, antimicrobials are drugs that destroy disease-causing microbes or pathogens. Most of these we are seeing as bacteria and viruses. The most important microbials are antibiotics, which treat bacterial infections. So antimicrobial resistance occurs when pathogens undergo evolutionary changes that enable them to withstand antimicrobials. And people and animals are encountering resistant pathogens, which may, in the long run, develop untreatable infections. Antimicrobial resistance is a natural process, but its spread has been dramatically accelerated by the overuse and misuse of antimicrobials. And research in the pipeline for new drugs has actually dried up, which should actually be of great concern. Well, most of the drivers of antimicrobial resistance are in human and in animals. We are seeing misuse and overuse in the animal sector and also in the human sector. So WHO has established or has called out for a global action plan on antimicrobial resistance, where it has developed 5 strategic objectives towards antimicrobial resistance. We see that the first strategic plan is to actually improve awareness and understanding of antimicrobial resistance, where communication and education should be strengthened. And the second strategy is to strengthen knowledge through surveillance and research, as well as reduce the incidence of infection, where we see infection prevention and control measures, WASH and hospital-acquired infections be curbed, as well as animal health prevention and control. The fourth objective is to optimize the use of antimicrobial medicines. This is where antimicrobial stewardship should be enhanced in our hospitals. And the fifth strategy is to ensure sustainable investment in countering antimicrobial resistance. So what is antimicrobial stewardship? We can define antimicrobial as destroying or inhibiting the growth of antimicroorganisms, and especially pathogenic microorganisms. Whereas stewardship is actually the activity or job of protecting and being responsible for something. In this case, being responsible for antimicrobials that are being used to treat infections. What is antimicrobial stewardship? This definition has been taken from the 2007 SHIA guidelines, where it defines it as a coordinated intervention designed to improve and measure the appropriate use of antibiotic agents by promoting the selection of optimal antibiotic drug regimens, including right dosing, right duration of therapy, and the right route of administration. It's actually a quality improvement program to augment individual clinicians in the best practice of prescribing these antimicrobials. And you want to minimize unintended consequences of emerging resistance, adverse drug reactions of these antimicrobials that are being prescribed, and Clostridium difficile that arises from taking these drugs. And you also want to minimize the costs. The goal, of course, of antimicrobial stewardship, you want to optimize patient care as well as the healthcare outcomes. Why do we need antimicrobial stewardship? We know, or we see antibiotics are a shared resource where in the hospitals, these antibiotics are misused, and up to 5% of its use or prescriptions are necessary or inappropriate. The antibiotics are actually a leading cause of emergency department visits for medication-related adverse events. We see those that are prescribed with cotrimoxazole coming in with SJS, and the overuse contributes to antibiotic resistance and the growing of the Clostridium difficile problem. So therefore, antimicrobial stewardship would improve antibiotic use in public health, which is imperative. So the how and the what of stewardship, at the base of this pyramid, we see a structural system prerequisite for an antimicrobial stewardship program, where we want to see antimicrobial stewardship team, as well as financial support for the team to actually conduct antimicrobial stewardship, as well as availability of a local antibiotic formulary or antibiogram. So in the middle of the pyramid is actually the what, where we want to see prescribing of antibiotics appropriately at the patient level. And how are we going to do this is actually a goal to improve antimicrobial stewardship. So the AMS team comprises of clinical pharmacists, ID physicians, clinical microbiologists, infection control, hospital epidemiologist, and an IT specialist. So this is what WHO has called for a stewardship team to comprise of, but we do know, or we do see that in Africa, low middle income countries, not all these specialties will be available, but we should at least each hospital or each facility should ensure at least of having a physician, a pharmacist, and a microbiologist. An added advantage is to have the IT specialist, hospital epidemiologist. So what does this stewardship team do? So it comes up with core strategies, and the core strategies that have been suggested to be put in place in these hospitals is prospective audit and feedback, as well as formulary restriction. In prospective audit and feedback, we'd in initial antibiotic prescriptions, prescribing occurs based on the prescriber's clinical judgment, and antibiotics are then reviewed by the stewardship team for appropriateness. So the advantage of having prospective audits and feedbacks can be done a few times a week compared to daily, and this also helps to facilitate a team approach to patient care and improves antimicrobial use and outcomes. Restriction formulations selects antimicrobials that require approval by specific individuals and ID physicians or the stewardship team members. You would select agents that are with a large cost, for example, vancomycin, or agents with a broad spectrum of activity, such as meropenem being prescribed only by ID physicians. This is an effective way of reducing targeted antimicrobes and can influence future prescribing practices. The CDC core elements of hospital antibiotic stewardship programs has come up with 7 core elements, such as leadership commitment, where dedicating necessary human, financial, and information technology resources, as well as accountability, where you need to appoint a single leader to be responsible for the team, and having drug expertise by appointing a pharmacist, and implementing at least one recommended action, tracking, where you monitor antibiotic use and report regularly on antibiotic use, as well as educate clinicians and other staff on antimicrobial use. Some stewardship interventions would be most antibiotic treatments should be started empirically as diagnosis is worked up. The CDC would recommend that clinicians should perform review of antibiotics 48 to 72 hours after antibiotics are initiated to answer the following questions. Does this patient have an infection that will respond to the antibiotics? So if so, is the patient on the right antibiotic, on the right dose, and the right route of administration? Or can a more targeted antibiotic be used instead? And how long should the patient receive these antibiotics? So a stewardship should develop and implement algorithms for assessment of patients suspected of having an infection and reducing prolonged antibiotic treatment for common infections. Now, we've seen the COVID-19 pandemic has actually disrupted quite a number of antimicrobial stewardship programs and interventions. We see that WHO COVID-19 dashboard as of September 7th, 2021, saw over 2 million confirmed cases.
We seem to be having some glitches there with Dr. Chuzi, so we're just going to give her maybe some moments while we try and get hold of her so that she can get back. Please bear with us. Okay, we'll just give Dr. Uchizi just maybe a minute. Oh, there she is, so that maybe she can reconnect.
Okay. Sorry about that. Okay, can you hear me?
Yes, we can.
Okay, and my screen is sharing?
Not yet, but we can see you. Okay, yeah, now it is.
Now it is, okay. Okay, so where was I? Talking about healthcare, talking about healthcare associated infections. We see that central line associated bloodstream infections saw an increase of 47%, while ventilator associated events saw an increase of 44.8% during this time of COVID-19. So here we do see that COVID-19 played quite a critical role in increasing antimicrobial resistance to of these infections. So here I'm displaying a number of papers that were Antimicrobial Stewardship, a paper by Diwale showed antimicrobial stewardship in ICUs during COVID-19 pandemic. Are we going back to the 90s? So many papers have been written during this COVID-19 pandemic, and trying to help us see, or trying to help us remember that antimicrobial stewardship, even during this COVID-19, should still continue. Otherwise, resistance will proliferate. So the rationale to decide to actually administer antibiotics in COVID-19 pandemic, in COVID-19 patients, antibiotics should be reserved for patients with the most severe respiratory failure, and then there's a need to withhold empiric antibiotics in patients with characteristic images for COVID-19 on CT scan. And if these antibiotics are started, we need to have the microbiological tests obtained beforehand, and a reevaluation of these antibiotics, whether there is need to stop them or de-escalate, is of importance. And antibiotic treatment should not exceed 5 days in most cases, and probably not given prophylactically to prevent bacterial pneumonia. Okay. right? So contributors to widespread and excessive prescription of antibiotics during this pandemic has actually taught or has seen a reflex by physicians to actually prescribe an antibiotic when a patient comes presenting with COVID-19. The first uncertainty surrounding the pandemic. You don't know which antimicrobial is actually working to actually alleviate the symptoms of COVID-19. There's been increased AMR resistance, antimicrobial resistance, and increased Clostridium difficile colitis because of the increased prescribing of some of these drugs that cause adverse drug events, mostly the penicillins. And we see that there's been a global supply chain of valuable medicines being potentially unavailable for those who actually need these drugs. And we also see that during this pandemic, an increased nursing workload associated with parenteral administration of antibiotics because of the patients presenting mostly with in a distressed way when they come to the emergency department. And many unintended negative long-term consequences have been associated with antibiotic overuse, potentially leading to increased morbidity and mortality. This will be seen definitely in the future, and other side effects of antibiotic, including cardiac aneurysms and kidney toxicities, have been noted with during this time. And this is no exception actually to our situation in Zambia. So the importance of a multidisciplinary team or collaboration across specialties during this time of the COVID pandemic has enforced a need to approach in treating these patients in a multidisciplinary way. And during this time, it has also promoted new relationships with the government and scientific community to see how best we can actually treat these patients. Multidisciplinary teams can include intensivists, nurses, ID specialists. This can be tailored, of course, to a certain facility or a hospital, respiratory specialists, surgeons, clinical pharmacists, and hospital epidemiologists. And multidisciplinary teams would enable approaches such as personalized medicine and hence enhancing disease prevention, diagnosis, and treatment. And multidisciplinary teams can also assist with the identification of bacterial infections. In one study, 98.5% of hospital doctors thought that antimicrobial stewardship must be continued and further developed during the COVID-19 pandemic. So prior to COVID-19 pandemic, hospital teams tended to function in a kind of restricted and more uncoordinated manner because they thought antimicrobial stewardship was not as important, but this kind of helped bring this team of various specialties together to help treat the pandemic. So greater discussions and meetings among healthcare practitioners to address the problems of non-compliance, and has also helped to better focus surveillance of poorly performing units. So let's look at the role of the pharmacists during in AMS. So most of these AMS interventions are or can be pharmacy-led, and pharmacists would enhance automatic changes from intravenous to oral antibiotic therapy, as well as help in making dose adjustments in cases of organ failure, such as renal adjustments for quite a number of drugs, for example, vancomycin, and would also help optimize dosages, including dose adjustments based on therapeutic drug monitoring, optimizing therapy for highly drug-resistant bacteria, and achieving central nervous system penetration or extended infusion administration of beta-lactams, etc. Pharmacists would also help in alerting doctors in that they need to actually review a patient after initiation of an antibiotic. They can also help in time-sensitive automatic stop orders for specified antibiotic prescriptions, especially antibiotics administered for surgical prophylaxis, and detection and prevention of antibiotic-related drug-drug interactions would facilitate pharmacy-led intervention. So antimicrobial stewardship timeouts are also quite important, and can also be pharmacy-led, where you take time out every day on a patient and ask the following question: whether the patient's antimicrobial therapy is actually rightfully indicated, and is my patient on the narrowest, most optimal treatment possible, and to decide whether an antimicrobial agent can be given orally, and is it dosed correctly, and how long does the patient need the antimicrobial therapy. So in dose optimization, you need to tailor the therapy to individual patient characteristics, considering factors such as the organism or pharmacokinetic or pharmacodynamics of the antimicrobial at play, where pharmacy would need to dose vancomycin or the aminoglycosides, or extended continuous infusion of the beta-lactams, or rather indeed give an alternative dosing regimen. Pharmacists would actually also look into converting intravenous to oral medication. This would save quite a lot of money and reduce the incidence of catheter-related infections, help also reduce length of stay and reduction of workload, all without compromising patient safety. So antimicrobial stewardship in Zambia, where are we? The National Action Plan that WHO instructed for each country to develop on antimicrobial resistance was implemented in 2017, and we see about only 7 hospitals that have set up AMS programs. So at the largest hospital in Zambia, the referral hospital in Zambia University Teaching Hospital, set up its antimicrobial stewardship program in 2018, consisting of ID physicians, pharmacists, microbiologists, nurse, and infection control. Our strategies included formulation of guidelines, which I'm glad to mention that we are going to launch them mid next month. Our IPC team, together with the AMS team, have actually producing hand sanitizers in the hospital and distributing them throughout the hospital. We have strategically restricted some drugs to ID physicians, as this will help save costs as well as actually streamline the prescribing of certain antibiotics that may be needed to be preserved for future use. A point prevalence survey was conducted last year, 2018, to actually see where we are with prescribing of antimicrobials. So some of the barriers and challenges that have been there or that we may face in implementation and delivery of antimicrobial stewardship is a limit. We have limited microbiology labs to actually have definitive diagnoses in the hospital, as well as lack of availability of the consumables for the laboratory. We are also lacking human resource and competencies, as well as standard operating procedures and quality assurance. Another barrier is access to quality assured antimicrobials, where sometimes we do have unstable access to essential antimicrobials, and most of these antimicrobials that ID consultants would actually prescribe are of high cost, and so the patient won't get the optimal antimicrobial prescribed to them. We also have we are seeing weak regulatory structures, where in the community, most patients or clients would go into the pharmacy and buy a cocktail of medicine. Some pharmacies have actually come up with a COVID pack where you have different kinds of antimicrobials as well as vitamins put into one pack, and a patient can actually buy these. So we have regulatory structures and guidelines need to be in place. Under resources, the healthcare professionals have competing priorities and little time for AMS work in the hospitals, and we are not seeing dedicated IT personnel to antimicrobial stewardship, and no electronic systems are available to actually alert physicians on a review, as well as financial resources for medicines, where we see during this COVID-19 pandemic that the financial resources were diverted .
We seem to be losing Dr. Achuzi. We'll just give her a moment to come
Lacking
back.
guidelines, though, like I mentioned, patients with antibiotics and output of outpatient antibiotic prescription is not controlled. We see poor compliance, therefore the ability to obtain antibiotics without a prescription. So in conclusion, or in summary, sorry about that.
Okay.
Sorry about that. I think my network is, let me just share that again. My network keeps dropping here. Can I So yeah, so I was just concluding to say that AMR is actually a huge problem and worldwide, not only in Africa, and early diagnosis is imperative. And empirical antibiotic treatment is of paramount importance to improve outcomes. Antimicrobial stewardship is important to avoid worsening AMR pandemic within the COVID-19 pandemic, and an intense antimicrobial stewardship program with an active enforcement from the institutional leaders is needed, and pharmacists are playing a critical role in dose optimization for a better patient outcome. And we need a lot more effort in leadership to implement and deliver antimicrobial stewardship. Thank you very much for listening in.
Okay, thank you so much. That was Dr. Uchuzi Chona from WHO Afro in Zambia with a very insightful presentation looking at antimicrobial stewardship, the importance thereof, as opposed to the antimicrobial resistance. Also touching on how COVID-19 pandemic did affect resistance, as well as also looking at hospital-acquired infections and their increase due to COVID-19, and I guess as well antimicrobial resistance because of probably the empirical treatment that was being given, and understandably so because it was a novel virus. So thank you so much for that insightful presentation, Dr. Chona. So without much further ado, we're just going to move into our next presentation. And our next presentation is looking at COVID-19 and how COVID-19 affected staffing when it comes to pharmacy, as well as pharmacy services. And to give us this presentation is Tambo John Cletus, who is a manager of quality assurance, and he's with the Central Pharmacy in Cameroon. Over to you, Tambo.
Good morning. A technical problem. I don't know if you can present from down there. Is it possible? Hello?
Hello?
Yeah, just greeting. I don't know if you can present from there. I have a very serious internet problem here, but I'm working towards getting the server on.
Okay, so we do have a host. Could the host please assist with Tambo's presentation?
Or can we get the second presenter, then I'll come in third. Is that possible?
Okay, let me share your slides. I do have them. So if the host has got the slides, please do assist by sharing as well. Okay, there we go. Okay, apologies everybody, we'll just share the slides. Okay, there we go. Okay, you can go ahead.
Okay. Okay. Thank you so very much. I'll be presenting using my phone, and I welcome every participant and all the presenters also. I am Tambo Cletus, as you have seen. I'm presenting the impact of COVID-19 on the pharmaceutical supply chain, and looking at CBC. I'm taking CBC as a case study. Who is CBC? CBC is Cameroon Baptist Convention, and it's a faith-based organization and has one of its sectors called the CBC Health Services. And it's of the CBC Health Services that hosts the central pharmacy that is in charge of procurement and distribution of pharmaceuticals. The CBC Health Services has 8 hospitals, 34 health centers, 4 lab posts, and then of the central pharmacy, of course, which is responsible, as I said, for manufacture, procurement, and supplies of pharmaceuticals to all these healthcare services or facilities. It has training schools, it has HIV programs, and it has services with people with disability and many others. Next. Hello?
The next one, okay.
Yes, next. Okay. Okay, good.
Hi, Tamba, you okay? Can we proceed?
Yes, hello, good. And then as an introduction, since its first outbreak in December 2019 in Wuhan, in China, just the history of the coronavirus. It has infected 200 and almost close to 238 million people as of the 11th of this October, and about over 4,800 have died. And of course, the trajectory and the transmission led by WHO has a global pandemic, declared global pandemic in 2020. Next slide. Next slide. Okay. The pharmaceutical sector is not left out anyway, and are considered to be some of the most accessible healthcare professionals. Excuse me. Okay. So I said, I'm having some difficulties here on network. Okay. I said the pandemic has almost brought the entire world to a standstill, and every sector has suffered a huge setback, including a double-figure decline in the major stock market. Because due to the travel restrictions and sometimes the closure of a lot of facilities, schools, universities, and so on, to mitigate the spread, to mitigate the spread of the virus, COVID-19 has severely affected countries' economy. Besides the already abysmal impact on every sector in the society, an increased risk of infection among the healthcare workers and the consequent staff absent due to the illness or the need to self-isolate has brought the biggest challenge in the provision of healthcare services. Healthcare systems in the developing countries are especially threatened because of the effect that the pandemic has, on the already weakened system in the country. Next. The pharmaceutical sector is one of the victims of the global health crisis. The impact of the pandemic on the pharmaceutical sector can be seen in different perspectives. In one hand, COVID-19 may be regarded as the century's opportunity for the pharmaceutical industry, as it increases the demand for prescription medicines, vaccines, and medical devices. On the other hand, it could also bring short-term and long-term detrimental impact on the pharmaceutical sector in general. Short-term impacts include fluctuation in demand, supply shortages, panic buying and stocking, regulatory changes, shift in communication, and promotion of remote interaction through technology and research. Research and development processes changes. Long-term impacts may include approval delays, moving towards self-sufficiency in pharmaceutical production supply chain, slowdown in industrial growth, and possible changes in consumption trends. Next. Hospital community pharmacies. Hospital and community pharmacies are considered to be some of the most accessible healthcare professionals to the public. There are a wide range of rules that pharmacies can make in response to various types of disasters, such as pandemics, across 4 key phases: prevention, preparedness, response, and recovery. Beyond ensuring the stable supply of key medications, pharmacies can play a significant role in reducing the spread of the pandemic through the provision of newly updated prevention methods, safety measures to their customers, updated information source about the corona infection, and new strategies to control the spread. Next. Next. The guideline in the International Pharmaceutical Federation for Pharmacies stated that pharmacies should join the medical team and have to give pharmaceutical care services. Moreover, community pharmacies can also give public services like early detection, appropriate referrals, as well as in supporting the implementation of government orders. Community pharmacies, therefore, should be on full alert and be familiarized with the latest updates of the pandemic and ensure all the necessary products and devices are available in sufficient quantity. Next. Now, we're looking at the impact of COVID-19 on the CBC Central Pharmacy Pharmaceutical Supply Chain. We're saying that we're taking a study example from the CBC Central Pharmacy Supply Chain. And as I said before, we have a lot of CBC health services, a lot of hospitals, health centers, and that across the Republic of Cameroon, 8 of the 10 regions of Cameroon. So it's a huge price to distribute these medications and pharmaceutical supplies. So it's looking at pharmaceutical commodities, it depends to patients.
Could we please mute our microphones?
There are a lot of interruption.
Sorry, Tambo, if you've got your microphone on, could you please mute it because we cannot hear the presentation. You can go on, Tambo, sorry. I'm not sure if our presenter is still on. Tambo, are you still with us? Okay, for the sake of time, maybe we'll just move on to the next presenter, and then after that presenter presents, we'll continue with where Tambo left off.
Hello?
Oh, hi.
Can you get me now?
Yes, I can. Just to say, our slides in the chat. It says I'm responding. Is this the right slide?
Okay.
Hello, Tambo?
Yes, hello. I can
Yes,
get
I'm
you now.
asking if, is this the right slide? If you look at the slide that I'm flighting right now, is this the right one?
Okay, let me. No, it's far down. Go to slide 8.
Am
Go
I
to
here?
slide 8. Slide number 8.
Let me know when to
Slide
stop.
number 8. Slide number 8.
This one?
Yes, this is the one.
Okay.
Yes, that is the one.
Thank you, Tambo. If we could just wrap it up as
Okay.
well for the sake of time. Thank you so much. You can go ahead.
Okay, can I go ahead?
Yes, you can go ahead.
Okay, thank you very much. Sorry for the interruptions. So slide 8, I was looking at the procurement pattern from procuring medications or supplies to supply to dispensing to patients. And I said the first item is the selection of international pre-qualified suppliers, request for quotations, placement of orders, payment of orders, shipment and reception of consignment at the CBC Central Pharmacy. Then QA or quality assurance and quality control analysis have to be done on the products before we have to ship them to the various healthcare facilities. Warehouse and management and distribution to all the healthcare facilities. Reception and management of pharmaceutical commodities in healthcare facility stores. Then dispensing of commodities to patients. Next slide, slide number 9. Oh, number 9. Okay.
Okay, so this is the order that we have. After this
Slide
one.
number 9.
This one?
Correct.
Okay.
Yes, on slide number 9. Yeah, challenges. Sorry, I'm trying to get things here. Okay.
Is it this one?
Go to slide number 9.
So when I've got these on slide mode, I cannot tell the slide numbers. So after this slide, the presentation we have is this slide.
Okay, let me come. This goes to slide number 9.
Is it this one?
Okay, yeah. Okay, slide number 9. Anyway, if that's slide number 9, then we'll have. Just give me 1 minute, please. The phone is so small. I want to get off my laptop and also.
Yes, we can. Okay, Tambo, if we could just go for a break. We've got a 5-minute
Okay.
health break while we sort that
Go
out.
to the first challenge. Slide number 9. Slide number 9.
Tambo, I was saying we've got a 5-minute
thank you so very much.
health break.
Thank you so much.
Hello? We've got a 5-minute health break for the interpreters.
Yes,
So we
yes.
can go offline and try and figure it out. Maybe we've got different slides, but these are the slides that were for your presentation. So thank you to the participants. Just take a 5-minute
Okay.
break.
Okay. Yeah, we can have it.
Yes, so we'll be back. We're just going to take a 5-minute break and then we'll be back with the rest of the presentations. And just to remind our participants as well, we cannot respond to raised hands. So if you've got any queries or questions, please put them in the Q&A because the chat will have like over 100 messages. So if you've got anything that's pertinent, please put it in the Q&A and then we'll respond to you. Thank you so much.
Thank you. Remember, this one is okay.
Invented antimicrobials, weapons that took this power from us and put them in control. We were no longer free to cause pain, disease, and death among humans, animals, and plants. But we waited, and humans made a fatal mistake. They used these precious medicines indiscriminately in humans, plants, and animals. Instance antimicrobials. Humans call this phenomenon antimicrobial resistance. We call it taking back control. Now we, the disease-causing microbes, can spread wider and faster where disorder, dirt, and disorganization reign. It's great for us when you have poor hygiene and don't use water and soap. We love when you flush your unused antimicrobials down the sink or toilet. They join our already huge colonies in your wastewater and river systems and make us stronger. Poorly managed hospitals to multiply and become new ruthless killing machines. Antimicrobials given to animals not to control or treat disease, but to make them grow faster. Create armies of microbes that become increasingly resistant. The beautiful thing is that the simple contact between infected animals and humans can allow us to spread. We can also circulate in contaminated food on plants, in the soil, and in water. We can be everywhere. We've regained some of our old power. However, I am becoming very vulnerable. Our enemies are starting to work together. International organizations and countries are starting to coordinate all sectors, from human, animal, culture, safety, to halt our glorious expansion and stay on top. They explain to me that we can be stopped by using antimicrobials as per licensed health professionals, such as doctors and veterinarians' advice, and not for growth promotion, by adequate wastewater management, and by having proper hygiene and cleanliness at the hospital and at the farm. Humans will become wiser. Keep us down. A disaster. Imagine if everyone listened to their advice. I am no longer safe. My ability to resist antimicrobials could disappear. Don't let antimicrobial resistance take control. Be responsible when using antimicrobials.
So welcome back, everybody. Apologies as well. I do know we've been having a few glitches with our sound, and I think it's also due to the internet for our presenters. But if you feel you missed something that's vital, Please feel free to put it in the Q&A, and then they can address it at the end of all the presentations. So just a reminder as well, can we please keep our microphones on mute while our presenters are presenting? So this is for quality of sound as well, and so that everybody can actually benefit from these presentations. And then just a reminder again, certificates will be given if you attend 4 of the 6 sessions for this particular series, and the presentations will be shared. So if you feel something was missed as well, all this will be shared. It's recorded, it will be shared with you, and all the presentations you can get, and as well as the links as well to the video that was just played, because we can see a few comments as speaking about the sound and it not being audible. So I'm not sure if Tambo, you're ready to present. We'll just give you, for the sake of time, maybe just an additional 5 minutes before we move to the next presenter.
Normal bed down to 15,000.
Hello.
Hi, Tambo, you're ready to present?
Yes, I can just finish within the next 5 minutes.
Okay, do you want me to flight it for you, or you can share the presentation yourself?
You can share it, but I will. You can share from there.
Okay.
I'm only using my phone
Which
now.
slide number should I start from?
That's slide number 9 under challenges. First challenges.
Okay.
Slide number 9, challenges.
Slide number 9, this one.
Slide number 9.
Yes.
Exactly. Yes,
Okay.
yes.
Okay,
Yes.
just for the sake of time, we'll just give you about 5 minutes so you can just
Yes,
round it up.
yes.
Thank you so much.
5 minutes. Okay. Yeah. Okay. Thank you very much for handing me the microphone. And I'm sorry for the technical faults. So we're looking at the challenges that the impact of COVID-19 has brought to pharmaceutical supply chain at the CBC Central Pharmacy here. The first challenge will be selection of pre-qualified suppliers, both local and internationally. This is because a lot of the suppliers had stopped supplying and most of the companies were closed. And so it became very difficult for the CBC Central Pharmacy to select pre-qualified suppliers, especially the ones that they had been dealing with. So the ones we have been dealing with, some of them were out of business because of the COVID-19. And so we had to look for new ones. And so it became a really big challenge to get everybody, especially those on board, to be able to supply for us. The next thing was to request for quotations. And on the quotations that we even request, you will have out of stock. A lot of them will not quote for every item that we've asked for. There will be a lot of out of stock on the quotation list. Then, of course, even when ordered, the lead time, we don't respect lead time because of all the different difficulties that the different companies and suppliers had. And so lead time never respected. Payment to international finance institutions that we normally used to do before 1919, before 2019, became difficult. Some of the banks were closed because, for example, in Europe and America, where we have foreign reserves there, we could not be able to supply India or China. With a tied up of all the different sectors within the health services of the CBC, there were limited finance to follow up all the different programs. The shipment and transportation, clearing costs all increased by about 30%. The cost of quality analysis also increased because the reagents that we used to get became so expensive. So to analyze the product before they are supplied to the various health facilities became much more expensive. Inland transportation had increased also by about 10%. Next slide. Okay, thank you very much. Then some pharmaceutical commodities were preferred to others due to the pandemic. For example, personal protective equipment, sanitizers. We went more for ethanol used to prepare sanitizers, and then disinfectants instead of medical commodities, resulting to most of out of stock of some of the medicines within the healthcare facilities. Again, shortage of pharmaceutical commodities due to border closure and lockdown and company closure. So that one it was a serious issue. Again, pharmaceutical commodity prices, both international and locally, went up by 40%. in 2020 and slightly went down the second quarter of this year by 30%. Then patient prices also went up accordingly, but then it became a big problem for CBC health services to maintain this kind of prices with very poor patients or people coming around. It became very difficult. So the prices were kind of trying to be maintained as they were before. Then poor patient turnout due to poor social media communication. A lot of media were saying that if you go to the hospital, they will inject you with COVID and you will die of COVID because the hospital, they want to get numbers of people who have died. So a lot of false communication through social media were going on and people were afraid to come to the hospitals. Next slide. Then most of the health services, I'm also using my computer laptop here. Most of the health services, healthcare facilities could not break even up to today due to the high running costs. Medicines were expensive, supplies were expensive, medical supplies were expensive, so everything went up. But then the hospitals could not cope with the running costs. Again, staff shortage due to COVID-19 infection. Some of the staff were infected and they had to be isolated. The issue of social distancing, the issue of regulation to say we don't want more than 5 people working in an office, 2 people working in an office. So staff, they had to cut down, and so it became a big problem. Of course, again, very little government subventions that were to come to boost the purchase of supplies was never there, or salaries and kind of thing. There was very little government subvention. Then some unscrupulous manufacturers, of course, and suppliers indulge in substandard and falsified pharmaceutical products. So because of the panic buying and rush for alcohol-based hand rubs or some medicines, for example, alcohol-based hand rub, a lot of them, we analyze them here and we found that some of them, instead of having between the 70 to 75% alcohol, some would have 20, some would have 10, which was very bad. And then, of course, some chloroquine that was accompanying the treatment, and dexamethasone had completely, some didn't even have any active ingredient inside, some had very low, leading to substandard medicine. And then it got inappropriate use of disinfectant leading to antimicrobial resistance. So just as I said, some disinfectants that were supplied in the market, they will say they give you the assay, or they give you the potent value, but at the end of the day, you find that it's very, very low. So you could not be able to appropriately use such things, and that could lead to antimicrobial resistance. More attention was given to pharmaceutical staff at the hospital dispensing window. More attention was given. Of course, at the pharmaceutical dispensing window, because of the infection of high level of infection of COVID-19, people had to give distances, and therefore coaching or advising patients on what to take became a big problem because no one wanted to go so close to any patient. A problem. And then non-standardized local protein commodity, for example, fresh mass and alcohol-based acid, not a double layer, folded, and the rest. Nobody obeyed the standards as given by WHO. So a lot of people were just doing anything in the name of fresh, and people were just. So it became a very big problem. Great need to be acquired because of this. Ability for a lot of healthcare facilities to have supplies. The vans were in limited supply, and so there was a great need to have more vans. Next slide. So, lesson learned. Develop and increase local production of pharmaceutical supplies. Give enough finance resources for emergency. Train staff adequately to handle pharmaceutical supply chain during pandemic. Government should subsidize health sector during pandemic. Great improvement of infection prevention, especially hand hygiene practice to reduce infection. COVID-19 testing has improved for more pharmaceutical supply chain staff because before they were refusing to test, but not a lot of them are now moving to test. Higher quality are being offered. Next slide. The last conclusion,
Apologies.
positive pharmaceutical workflow has
Sorry,
been
Tambo.
immune to the shifting healthcare
Tambo.
landscape caused by COVID-19.
Hello?
Ah,
Hi, Tambo.
hello.
Sorry. Hello?
Yes.
I'm sorry, your network is bad. Thank you so much for that presentation. But for the sake of time, as it's eating away into the next presenter's
Hello,
time, and
yes.
hello?
I'm getting you.
Yes.
Can you hear
Unfortunately,
me? Yeah,
yes, I
I'm
can
getting
hear
you.
you.
Oh my
Yes,
God.
unfortunately, we have to move on to the next
Hello,
presentation.
I can hear you.
Yes.
I can hear you, but
Unfortunately,
I don't
we have
know.
to move on to the next presentation. Thank you so much.
I can hear you.
You cannot or
Okay,
you
no problem.
can.
Thank you very much. That's the
Thank
problem
you
that
so
we have
much.
to
Yes, so to our
mention.
participants, if you've got any questions for Tambo, please put them in the Q&A. And maybe, unfortunately, today we won't have enough time to go through all the questions and with our presenters, but we will collate the questions and also send the answers to you if we do not get an opportunity to answer them in this session. Without further ado, I would just like to welcome our last presenter, who's going to be looking at antimicrobial resistance, looking at the country perspective. And this is Talia Yaya, who is a senior technical advisor with medical technologies and pharmaceutical services with management services for health in Tanzania. She's a doctor with a master's in public health and several years of coordinating quality programs at the national level. And her role at MSH include global health security agenda, interventions, design, implementation in improving antimicrobial stewardship at national and facility level. So without much further ado, over to you, Talia. You can go ahead and share your slides. Thank you.
Yes, can you see the slide?
Yes, we can. If you can put it on slideshow.
Slideshow, yes.
Yeah. Just click on slideshow.
Yes, I'm looking for the slideshow.
Yeah,
Yes.
right there, and then from beginning. Thank you.
Yes, can you see it clearly?
Yes, thank you.
Yes, thank you now for the invitation. And
I just also introduced you are standing in for Talia, just to
yes,
clarify.
and unfortunately, my colleague, Dr. Tal here, I've got an emergency commitment, so I have to represent her and present, and she is my fellow colleague. We are implementing together. I'm Stefano Simba, a technical advisor for MTAPS, USAID MTAPS program in Tanzania, implemented by Management Sciences for Health, Tanzania. So I'm glad to be with you in this presentation. So I'm going to present on country perspective roadmap on AMR implementation in Tanzania. And this is my layout of my presentation. I'll take you through milestones of AMR. Also, we shall look at National Action Plan on antimicrobial resistance, as well as governance and strategic objective. Then we shall look at conclusion and the next step in Tanzania, and any other business that you raise up during a presentation. So this is the summary of milestone on the AMR implementation in Tanzania. And as you can see, in the summary that the history behind started from 2015 on situational analysis conducted in Tanzania, and followed by joint external evaluation in 2016. After joint external evaluation, one of the recommendations from WHO, it was to develop national action plan. That in Tanzania, we developed the national action plan in 2017, and in 2018, followed by development of antimicrobial resistance surveillance framework. Also, we developed the policy guideline on implementing antimicrobial stewardship in Tanzania in 2020, and also in 2020, we developed as a country multi-sectoral antimicrobial resistance communication strategy for each partner and the ministry. So all these initiatives was led by 3 ministries: Ministry of Health, Ministry of Livestock and Agriculture, also in cooperation with the different implementing partners, including implementation SNAP AMR project, also implementation HATUA project, enrollment GLASS, also implementation Framing Fund project, implementation IDDS project, as well as our program MTAPS, Medicine Technologies and Pharmaceutical Services in Tanzania. So from that milestone, I give you some of the snapshot from that milestone implementation that in Tanzania in 2016 started with the WHO, conducted a joint external evaluation using the International Health Regulation tool. And this is the summary of the score in Tanzania, whereby in antimicrobial resistance detection, we scored 1, surveillance of infectious disease caused by AMR pathogens, we scored 1. Also, healthcare associated infection prevention and control programs, we scored 3, as well as antimicrobial stewardship activities, we scored 1. You can see a bit that in IPC, infection prevention and control, it's the area that we scored a bit 3 out of 1 in the other areas left. So this is the implementation. As I mentioned before, this is the picture of the National Action Plan on antimicrobial resistance. We developed it in 2017, that it is 5 years plan that will go to 2022. And this address the recommendation for WHO as they agreed that it should be developed. Also, the NAPA National Action Plan is coherent to the Global Action Plan on AMR with similar strategic objectives. So this is the summary of governance in Tanzania to deal with the antimicrobial resistance. It is led by MCC at the center. It is multi-sectoral coordination committee. And this multi-sector coordination committee chairperson is Chief Medical Officer, is a chairperson of this MCC, and the co-chairperson is in Division of Veterinary, is DVS, Director of Veterinary Services, is a co-chairperson, because this is the one healthy approach. So we are dealing with the health on human, animal, and the livestock. So as a center, MCC is cooperated with the WHO, FAO, CDC, Prime Minister Office, Ministry of Health, Ministry of Agriculture, Livestock. Also, different academics are cooperating together with the in MCC. Also, this MCC have got a secretariat which led the implementation of MCC. And this MCC is fed by 4 technical working groups, one of which on AMR awareness, Second is the AMR surveillance. Third is AMR IPC. And the fifth is antimicrobial stewardship. So in MTAP's program, we are dealing mainly in two technical working groups to fed into MCC, which is the IPC, and the antimicrobial stewardship technical working groups. So this is the WHO strategic objective, 5 strategic objectives recommended. First, to improve awareness and understanding of AMR. Secondly, strengthening the knowledge and evidence base through surveillance and research. Third, reduce the incidence of infection through effective hygiene and IPC. Fourth, or to optimize the use of antimicrobials. Also, the last fifth is to ensure sustainable investment through research and development. So I'm going to explain one by another as it is implemented in Tanzania. So the strategic objective number 1 on improving awareness and the understanding of AMR in Tanzania. We developed the multi-sector antimicrobial resistance communication strategy that help moving from awareness to action. So this developed in 2020 and will end up on 2025. And this is developed in cooperation with 3 ministries: Ministry of Health, Ministry of Agriculture, and the Livestock. Also, the MCC is one, and the AMR Awareness Technical Working Group is the one leading this awareness. Also, the 3 secretaries, permanent secretaries, the responsible for their respective ministries, they are one that signed the communication strategy. So you can see some of the awareness activities. Here is the symposium on antimicrobial resistance that was launched, that used to launch the National Action Plan in 2017. This is some of the event. We had symposium. At the bottom photo, there was awareness among secondary school students. As we know, antimicrobial resistance is broad, and it goes from child to adult, from animal, from human, animal, and the livestock. So environment is concerned. This is also the picture for MCC during Awareness Week. And these are some of the members of MCC meeting during Awareness Week. We celebrated in 2017. Also, this is some of the events done in Dodoma during Awareness Week on antimicrobial resistance. Wow. So there was different events like meeting, awareness to the community member. You can see at the left side, community member, so that they can know and strategize on how to address. So strategic objective number 2 on evidence-based. In Tanzania, we developed the National Antimicrobial Resistance Surveillance Framework. As I said, 3 ministries, and led by MCC and signed by the permanent secretaries of the respective ministry. And this helps in IDDS take a great lead of this on infectious disease detection and the prevalence that involving laboratory investigation and the data in antimicrobial resistance containment. Also, strategic objective number 3 on effective hygiene and IPC implementation. As MTAP's program in Tanzania, USAID MTAP's program in Tanzania, we supported IPC. We are supporting IPC activities. Some of them is to review IPC guideline and the SOP on AMR incorporated. Also, development of IPC training package for use at your level in healthcare delivery. Not only we are implementing the program in 10 hospitals from 7 regions in Tanzania, but these materials developed are used countrywide. Also we supported development of online course on IPC that facilitators, tutors, and other healthcare workers can log in and attend course online. Also, development of monitoring and evaluation system for IPC indicators. We supported the development of IPC indicators in DHIS2, and those indicators soon is going to be fed into the system, the national countrywide system for reporting health data as a warehouse, so that all the health facilities will be reporting in the system, and that will serve as a database for implementation. So this is some of the implementation. You can see we supported health facility to conduct self-assessment, and in 2021, Q1, 18 health facilities was conducted self-assessment, raised up to 23, up to in Q3, ended up on August. On June, 25 health facilities were able to conduct a self-assessment in Tanzania. Also, you can see at the left-hand lower picture that the healthcare workers, health attendant was used to carry the bed sheets on hand, but nowadays due to IPC improvement, they use the special trolley to carry the bed sheets. Also, this is the picture for national e-learning platform for the online course on IPC. This is the snapshot for the DHIS2 system to report monitoring and evaluation of IPC. So the strategic objective number 4, I don't see well, it is the policy guideline development to address the use of antimicrobials. We developed a policy guideline on antimicrobial stewardship. As I said, 3 ministries was collaborated. So in IPC, also, we supported stewardship activities in review standard treatment guideline within National Essential Medicine listing, whereby the aware categorization of antibiotics is included, and he insisted on following the aware categorization. Also, we supported development of MTC guideline. Also conducted mentorship in 10 hospitals. We support also development of ethical prescribing and ethical dispensing materials. Also, we plan to train healthcare workers in 10 hospitals we support, but we shall be cascaded as the plan of the ministry on ethical prescribing and the dissemination of those guidelines. On regulations, that in animal health, that in Tanzania, regulation of import and export of animal fed resources have been developed. Also, upon importation, there is antimicrobial resistance certification as part of certificate of analysis of importation of animal products. Also, the regulation for registration of animal fed resources product have been developed. Also, both the regulation and under the Grazing Land Animal Feed Resource Act have been developed to make sure that we monitor. So by concluding that antimicrobial resistance is a public health issue in Tanzania, and it cuts across, it is in wide range from animal, livestock, and the agriculture, environment as well. So it's a big issue as a public health concern. Also, National Action Plan has been used as a starting point to address antimicrobial resistance in the country. Also, One Healthy Approach concept is one of the strong points nationally. However, there is a need to strong collaboration at national and subnational levels. So in Tanzania, the next step, we are planning to cascade the implementation of antimicrobial stewardship toward the containment of antimicrobial resistance nationwide. Also, after the end of National Action Plan on the AMR 2022, we plan for evaluation and looking for next step toward the improvement of antimicrobial stewardship implementation and AMR containment. Thank you very much for listening. I welcome question in the chat as mentioned by the coordinator. Thank you very much.
Thank you so much, Stefano Simba, for that very insightful presentation. It's always good, I think, to have examples of programs that are working, the challenges they're facing, what they did well, what has not worked, because it's such lessons as well that also assist us maybe for setting up such programs within our respective countries. Apologies once again to our participants for the glitches, I guess, which resulted in all our time being eaten away, but I'm sure you did get something in this very insightful session that was looking at antimicrobial stewardship, antimicrobial resistance, and also looking at it in the context of COVID-19, and of course, infection prevention and control. And for the sake of time again, not much time to questions, but I will pick one question, maybe to direct to one of our presenters, and then for the rest of the questions, we've got approximately 3 questions. We're just going to ask our host to take those down, and then they will be answered via email to the ones that were asked, or then it will be shared maybe broadly to everybody, because I'm sure everybody's interested in the answer. So the question is directed at Dr. Uchuzi. I hope you're still with us, and the question is around AMR. It says, I'm a veterinarian from Kenya. How do you link AMR in vet medicine since coronavirus is common in animals? Is it zoonotic? So I hope you're online, Dr. Uchuzi, maybe to help us with answer to that question.
Yes, I am online. So I think right from the beginning of when the pandemic started, I think we did hear that it started, the coronavirus started in bats and was passed on to humans and so on. So, so you're asking whether the coronavirus is common in animals? So look, I was reading through the WHO and CDC and all these papers that have come up. So yes, they are saying that the coronavirus is zoonotic. However, would I link AMR in vet medicine? So we see that most of the antibiotics, or some antibiotics, are given to these animals, and so you would say that most of these antibiotics that are given to the animals, they will not all be eliminated from their system. And so when an animal is killed and thereafter cooked and eaten by humans, some of these antibiotics do actually sediment in bone marrow as well. You see also in chickens, you know how chicken, you can suck off bone marrow from, and actually eat bone marrow as well from cows. So some of those antibiotics do actually stay in the bone marrow. And some of those antibiotics are penicillins, which again, if you are also taking in most of these antibiotics because of misuse and overuse of these antibiotics, you will develop resistance. So I don't know if I have adequately answered it. Maybe my colleagues as well can answer, can add on to that.
Do we have anybody within the panelists maybe who also wants to add on to Dr. Chu's answer? Okay. Well, thank you so much to everybody. Thank you for, thank you to our participants for being patient with us as well. Thank you so much to our presenters who came and offered us some insights into our topic of today, which had to do with antimicrobial stewardship. And we're looking at it in the context of Africa, of course, because our challenges are not the same globally. Africa's got its own unique challenges. And of course, we also touched on infection prevention and control. I can see some questions as well on the presentations. These will be shared to you. This is a recorded session. And then when it comes to certification, if you have attended 4 of the 6 sessions within the series, you will get certification. And just as a reminder before we log off, that we do have the 8th ICAN Congress 2021, and you can go to the ICAN site on how to register for this Congress, which will also be very helpful, very insightful, very educative when we're looking at infection prevention and control. So without further ado, I would also like to thank those behind the scenes, our interpreters as well, and everybody who helped to put this together. With that, I hope you do register for our next session, which will be next Wednesday. So have a good day. And the questions, we are just going to collect the ones that have not been answered and send them to our presenters, and they will be answered before the end of the week. So thank you so much, and I hope you all have a good day.
Thank you. Thank you for having us.
Thank you all. Bye-bye.
Bye-bye.
Thank you so very much. Bye-bye.